Good afternoon, everyone. Thank you for joining us. This is Eve Green Coopersmith of Garfunkel Wild. I will be joined today by my partner, Lourdes Martinez. Our focus of today's webinar is on nursing facility updates. We're going to discuss the 1135 waivers from the federal government, the New York State executive orders, which change on a daily basis, the Emergency Treatment Protection Act, which is the immunity statute in New York, and we'll also talk about the telehealth expansion. So we're going to get right to it, but I do want to mention first that this webinar will be recorded, and everyone who has registered will have an opportunity to have the slides as well as the webinar itself, so you can share that with other folks in your facility. So let's start right off with the 1135 waivers. These are the waivers that are issued by the Department of Health and Human Services. There are two types of waivers. There are blanket waivers, which are issued across the country, and then there are individualized state waivers, and there can also be provider waivers as well. But it is important to note that these waivers only apply to the federal requirements. And obviously, we know the conditions of participation for nursing facilities are quite broad and detailed, but many states have their own requirements as well, as does New York. In New York, the governor has issued executive orders. It's 22 as of today. There could be another one coming out today. But there are many executive orders that have been issued on all kinds of things. We will talk today about the executive orders that apply to nursing facilities. And then there are also guidances that are being issued and updated regularly. So if you have guidances, I would recommend that you go back and look to see whether there's been some further update, because there have been changes. CMS has issued guidances, the CDC has issued guidances, as well as the New York State Department of Health. They're issued either as a guidance or a health advisory. So those are things that you should be looking to.
So let me jump in here for a second, because what we meant to do, and this is Lourdes Martinez, what we meant to do is kind of put together a compilation of the relevant waivers and the relevant executive orders in the nursing home industry to date. But in our disclaimer here, as Eve has said, one of the issues is that, and you all know this is changing by the second. So this is current as of 12 o'clock on April 21st, but we can't say what will happen later on today or tomorrow.
And to Lourdes's point, the Federal Register was published today, and I'll try to talk about that a little bit, but it happened so quickly. It's not in our slide presentation, but we will try to touch upon some of the more recent things that came out yesterday and today. But things do change so rapidly that we recommend that you certainly check back to updates of the guidances that you already have. So with respect to some of the blanket waivers that were issued by the federal government, every nursing facility knows that you have to have a qualifying hospital stay of 3 days prior to admission. But that is one of the things that's now been waived as a result of COVID-19. And it's during this public health emergency, right? This is only going to be effective. That's also something, and a caveat you should be aware of, that all of these waivers only apply during the public health emergency. The moment that is declared over, we're back to, unless there's been some change, you have to assume that it's going back to what it was before. So the 3-day hospital qualifying stay has been waived for those who may experience dislocations or otherwise affected by COVID-19. In addition, there's a provision that says that for certain beneficiaries who had recently exhausted their nursing home benefits, but they weren't able to complete their being out of the nursing home and having everything recertified. So for those beneficiaries who were delayed or prevented by this public health emergency from either commencing or completing the process to have their benefits recycled, there's also a waiver with respect to that. Various types of assessments have been waived during the public health emergency. The MDS requirements, the time frame for that is suspended for all the different time frames that there are. The PASRR requirements, remember that there was a recent proposed change of the PASRR requirements that was published in February. There are some significant changes happening to the PASRR requirements, but during the public health emergency, a number of things have happened. One, the comment period with respect to those proposed rules is extended, and PASRR assessments themselves are suspended for new residents for 30 days. But after 30 days, you must promptly do a PASRR assessment for every resident that's been admitted who has a mental illness or intellectual disability. New York actually said that it should be done as soon as practicable, but the 1135 waiver says promptly. In New York, there is an executive order that waives the requirement that a patient review instrument be completed prior to admission to a nursing home. That now has to be done as soon as practicable. So that's, as you know, a significant change as well. Again, this is all designed to facilitate the rapid admission of patients to nursing facilities to alleviate the burdens on hospitals. With respect to assessments, once you're in the nursing home, the comprehensive assessments that are required, when there's been this temporary evacuation during the public health emergency, it is not required that the assessments be performed at the time of admission when they were evacuated. This is something that you can also have physicians and other practitioners. So a physician can delegate to a nurse practitioner or a physician assistant or a clinical nurse specialist who is not employed by the facility. They can now perform the visits that are otherwise required. In addition, there's a big push, obviously, towards telehealth. So under the 1135 waivers, physicians and non-physician practitioners can satisfy the 30-day and 60-day in-person visits by using telehealth. In New York State, the executive order is requiring that orders be issued as soon as practicable after admission. Again, understanding that there is this big push towards admitting residents and providing the appropriate care that must be provided. That's one thing that's never been waived. With respect to admission issues in particular, the Department of Health has issued a guidance that nursing homes are prohibited from denying admission or the readmission of any resident solely on the basis of having a confirmed or a suspected diagnosis of COVID-19. Nursing homes are not permitted to require that there be a COVID-19 test before admitting or readmitting a resident. Of course, you can always deny admission of a prospective or returning resident who is not medically stable. And if the nursing home does not have appropriate resources to properly take care of the resident, that's another basis upon which you could argue that you're not able to take care of the resident at that time. Lack of staff, supplies, and equipment are considered the kinds of things that may be appropriate resources, but I would caution you to be careful with that because there are PPE shortages. We'll talk a little bit about that later. So I wouldn't use that, I'd be very cautious about using that as the reason why you can't accept a resident.
And let me just jump in here for a second, because while, I totally agree with Eve that we have to be careful if that's our reason, I've gotten a lot of calls and a lot of nursing homes basically calling and saying, I cannot do it. I cannot take another patient safely. So, while you have to be careful, it is absolutely a reason that we can use to not take somebody if it isn't safe for us to take them back.
And obviously that's something that you're going to document so that you can protect yourself. CMS has issued a guidance that nursing homes should admit any individual that they would normally admit, including individuals that are coming from hospitals where COVID-19 is present or the individual is diagnosed with that. But they're recommending that you follow transmission-based precautions and that you follow the CDC guidance. And on this slide, as well as the next slide, I have given you the two web addresses for the interim additional guidance issued by CMS for infection and prevention control applicable to nursing homes, and also the interim clinical guidance for the management of patients with confirmed COVID-19. And I will tell you that these particular guidances have been updated more than once. So CMS's recommendations have changed. I believe that one of these guidances was just updated, I think, on the 15th of April. So again, check the most up-to-date guidance. If you've got it, make sure you refresh your page on your computer so that you get the most up-to-date guidance with respect to how to manage patients, because it has changed. With respect to life, activities and whatnot in a nursing facility, both CMS and the Department of Health are recommending that the normal activities that you would have, as you all know, have to be suspended. Communal dining, all group activities have to be suspended during this public health emergency. We're exercising, severe social distancing. If it's not, feasible to cease communal dining, then you have to institute safe distancing practices. You have to remind residents to always practice social distancing and to perform frequent hand hygiene. We have to educate the residents as to the proper behavior here. All staff have to be screened at the beginning of their shift for fever and respiratory symptoms. CMS is recommending that nursing facilities implement their sick leave policies, remind healthcare practitioners not to report to work when they're ill, and that any healthcare practitioner that has a fever of 100 or above or symptoms of COVID-19 be sent home and leave the workplace with their mask on. CMS also was recommending that with respect to screening, that you document the fact that the staff do not have a fever and do not pose symptoms at the beginning of every shift. With respect to rooms and roommates, we have a blanket waiver from the federal government that for purposes of grouping and cohorting residents with respiratory symptoms or illness, residents with confirmed diagnoses, we can separate them from other residents who are asymptomatic or test negative. And there are certain basic rights that are part of the conditions of participation that are waived. So the right to share a room with a roommate of your choice, the right to receive written notice of the room change and the reason for the change before you have that, before the transfer, and the right to refuse transfer to another room. Those things have been waived to allow you to cohort residents and protect residents as well. And it also aligns with the CDC guidance to preferably place residents in locations that are designed to care for people who have COVID-19 and to also prevent the transmission to other residents. The notification requirements now, let's talk a little bit about this. This is something that's fairly recent. We had to update this actually this morning. There were executive orders that were issued over the weekend by New York State, where this is now a requirement. Nursing facilities are now required to notify a resident's family member and next of kin if any resident in the facility tests positive for COVID-19 or suffers a COVID-19 related death. And the notice has to be given within 24 hours of the positive test result or the death. Now, there's been some question as to, because of the wording of, there are two executive orders here that were issued, one just the requirement, and then the second executive order had the enforcement provisions that said non-compliance with these notice requirements can result in a penalty of $2,000 per day, and subsequent violations can be can be punishable pursuant to the provisions of the public health law, which is either a misdemeanor or a fine, or both. So there certainly can be significant consequences. But to answer the question of, well, is this just when, are we notifying family members when just when their family member, their loved one is the one who tested positive for COVID-19, or that was the person who expired? The executive orders were not entirely clear, but there was a prior Department of Health guidance that went out to all nursing facilities and adult care facilities. And in that guidance, DOH was strongly recommending to facilities that they notify family whenever any person in the facility tested positive for COVID-19 on the same day that the facility learned of that. And the reason for that was to have transparency so that the families would know what was going on at the facility, whether the facility was caring for residents who had COVID-19 and, whether there was, issues with that. So we're reading this as the new executive orders as requiring facilities to notify and family whenever anybody in the facility tests positive.
So Eve, I don't mean to interrupt you, or yes, I did, but anyway, could you just discuss for a second, because one of the issues in the nursing homes is that not all of the nursing homes are testing. Some started testing in the beginning and then were told to stop testing. So what if there is no actual positive test for COVID-19, but there are people with the symptomology that would clinically make you think that they have COVID-19?
Well, if we go back to, I'm going to jump ahead a little bit because I think that this relates to what we're going to talk about in a moment in terms of what lies ahead. I believe this is going to be subsumed. I understand that the executive order was very sparsely worded. The Department of Health memorandum was much more detailed in saying that they wanted there to be this transparency. And I don't have a copy of that printout in front of me, but there certainly was this, goal to have transparency. But in talking about what lies ahead, CMS is tackling this issue. And CMS has indicated, and it just announced in the last day or so, that they intend to issue new regulations that are going to be stricter than New York State's reporting requirement and the reporting to families, the notice to families. And I'll jump ahead and then go back. So with respect to notifying residents and their family members, CMS has indicated in their pronouncement just, I guess, a couple days ago that they intend to issue a regulation that is going to require facilities to notify residents and their family members within 12 hours of the occurrence of a single confirmed infection or 3 or more residents or staff with new onset of respiratory symptoms that occur within 72 hours. So they're looking at not just the confirmed test, but also the residents and staff that are showing signs and symptoms of COVID-19. And
this would also go towards your point that you said before, Eve, that it would apply to all the residents in the nursing home, not just the resident who tests positive or their family member.
Yes, I believe I believe that the executive order was sort of trying to codify the Department of Health's strong recommendation to nursing facilities and adult care facilities. It was done in one memorandum that did talk about, being more transparent about what's going on in the facility. That's how they characterize it. We want you to be notifying families what's going on in the facility, which is not just what's going on with your loved one, because facilities are always required to notify the family when there's been a significant change in the patient's condition, if the family is involved in healthcare decision-making and things of that nature. We're always required to do that. So this in some ways is no different. So these reporting requirements would go further. And what CMS has said is not just to notify within 12 hours, but then to give updates whenever there's a subsequent confirmed infection or 3 or more people, have new onset of symptoms, and also include information to family members on what are the steps that the facility is taking to try to mitigate and prevent the risk of transmission to other residents who are not ill. So that,
Right.
I think the New York's
I
report.
just want to jump in because this is going to be, and hopefully when the guidance comes out, it's not going to be as bad as it reads right now, but this is going to be extremely onerous on the nursing homes to do these notifications. And I also just want to say kind of a rule of thumb for those of you who may have forgotten, when the federal regulations and the state regulations conflict or aren't the same, the rule of thumb is we usually have to do whichever one is most restrictive and which is hardest. So we are going to have to abide by these regulations by this guidance when it comes out.
But to your point, Lourdes, I hope that perhaps they're not as onerous as CMS has pronounced that they will be. So I think we have to wait and see, because to notify representatives within 12 hours, if you're in a hot spot, that's just going to be very, very difficult.
Right. Yeah. I mean, if you have somebody who you find out tests positive at 8 o'clock at night, by 8 o'clock in the morning, you're going to notify everyone. I mean, it's asking a lot. But anyway, go ahead.
Right. So I'm going to just go backwards a moment too, because in that same CMS announcement about upcoming requirements, CMS is planning to require that nursing facilities report communicable diseases to the CDC. We already have a requirement to report communicable diseases to the state and local health departments, right? That's something that we already do. But this is going to further require that nursing facilities report to the CDC. And what CMS says is they will provide specific direction on a standard format and frequency to report that information. So that also remains to be seen. In addition, in that same pronouncement, CMS warns that the failure to report resident and staff incidences of communicable disease or infection will be grounds for an enforcement action, and failure to, for 2 things, right? For failure to provide timely notification for residents and their families, as required, as well as failure to report, I think, to the CDC. So these are things that would be part of the potential enforcement action, as if we didn't have enough to worry about. Okay, and in addition to blanket waivers, the CMS, it wasn't a blanket waiver, but CMS did issue a guidance that no visitors will be allowed. New York State adopted that, much earlier, but no visitors are allowed to visit. There are some exceptions that can be made on a case-by-case basis. So if you have, an end-of-life situation for compassionate reasons, you can allow someone to come into the facility. You would have to limit that person to a specific room only. You'd have to screen that visitor for fever and respiratory symptoms to prevent anybody from coming in, including clergy if that's the case, and bereavement counselors. And you must require that the visitors perform hand hygiene or use PPE, such as face masks. So there can be those certain limited exceptions for allowing visitors. And I am aware that some facilities are doing just that. They are allowing on a case-by-case basis, particularly when it's end of life, for a family to come to be at the bedside of their loved one. Let's spend a few minutes talking about the discharge and transfer issues, because CMS did issue a blanket waiver to allow residents to be transferred and discharged from a facility to another one for purposes of cohorting. So there's three types of situations that can be done. One is to transfer a resident who has symptoms of a respiratory infection or a confirmed diagnosis to another facility that agrees to accept each specific resident. You have to have that agreement for each specific resident, and that facility has to be dedicated to the care of such residents. So that's one, where we're transferring people who are ill to a receiving facility. The second scenario is we are transferring people who are not ill, who do not have symptoms of respiratory infection, who do not have a confirmed COVID-19 diagnosis, to a facility that agrees to accept that specific resident and is dedicated to caring for residents to prevent them from acquiring COVID-19. Or the third scenario is you're transferring residents without symptoms of a respiratory infection to another facility that agrees to accept them and observe them for infection for a period of 14 days. So there are some requirements in order to do this. And I am aware of some operators trying to do something just like this. They're trying to create one facility that's just going to be a COVID-19 facility, and then there'll be, or another facility that's going to try to be COVID-free. Under the 1135 waiver, there are certain discharge and transfer regulations that are waived to allow these types of transfers to happen, right? So the first is the right to have advance notification, right? Anytime you're transferring or discharging a resident, you have to give them an advance written notice, and they have to get a copy of your bed hold policy in the right of readmission. Those regulations are waived, right? So the right to have advance notice, the right to have a written notice of discharge prior to transfer, and the right to get a copy of the bed hold policy and readmission policy prior to transfer. All of that is waived. You still have to provide it, but it would be after. It doesn't have to be before. And in addition, the receiving facilities also have a waiver that applies to them. The requirement that a baseline care plan be developed within 48 hours is waived. That if you did a comprehensive care plan instead of a baseline care plan, that's waived. Essentially, you really have to the receiving facility must complete the required care plans as soon as practicable, right? And then they're expected to review and use the care plans that they're getting upon admission from the transferring facility. So they have to provide appropriate care, but the requirements with respect to timing is what has been waived. What is not waived, and I've gotten this question, is the requirement that for other types of discharges and transfers, we still have to do the 30-day notice of discharge. So we still have that issue to deal with if it's going to be any other type of transfer or discharge. So now I'll turn it over to Lourdes to talk about staffing.
Okay, so one of the most commonly occurring questions that I'm getting is about staffing issues. So I'm getting questions of, can we bring back retired individuals on a voluntary basis who don't keep their licenses current? Could we bring people that are just finishing school but haven't taken the appropriate licensure or boards? Can we bring them on? Can we bring on new CNAs that don't have the requisite training? So hopefully I will be able to answer all of those questions as I go through this section. Before I do that, though, I did notice while Eve was speaking that we're getting some questions that we will address at the end of the webinar. So, you know, the first slide is easy. The PBJ data submission requirements, those are waived for now during the emergency order. Hold on, I'm having a little, okay. So the federal government, the 1135 waiver, so the requirement that a nursing home not employ anybody who doesn't have the requisite CNA training and certification requirements for more than 4 months, that requirement is waived. However, the individual has to be competent to provide the CNA services. So how are we going to do that? The facility has to ensure that the CNAs actually have the ability and the skills to do the services that we need them to provide. And my recommendation is that we do the onboarding like we normally do in the facility, that we keep track of the onboarding and the training that we do, and that we also keep track of the observations. So if obviously making it up, but if the skill is, a bed transfer, that we have documentation to show that we've taught them the bed transfer and that we have also viewed them doing it on their own and they know how to do the bed transfer. So I think that we need to keep documentation of the training that we are doing within the facility. Okay, out-of-state practitioners. So doctors that are licensed in another state can provide services in New York State without a New York State license. However, there are caveats, and I've gotten this question over and over again. The caveats are the doctors have got to be enrolled in Medicare. Now, this is the federal waiver, the 1135. The doctors have to be enrolled in Medicare. They must have a valid license in whatever state they happen to be practicing in. They can't, this is the big question that I'm getting. You cannot be an excluded provider and now be providing these services. So these four caveats have to be fulfilled. I actually missed number 3. The services that are being furnished, whether in person or telehealth, has to be in a state where the emergency is occurring. Okay, so this is all during the pandemic where there is an emergency. But again, you cannot take a physician who has been, or a non-physician practitioner who has been excluded from Medicare. Okay, New York executive order. So the following individuals, if they are licensed and in current good standing in any state, or, and this is new as of yesterday or the day before, or in Canada, they can practice in New York without civil or criminal penalty related to not being licensed in New York, and those are physicians, physician assistants, RNs, LPNs, nurse practitioners, clinical nurse specialists, social workers, and radiologic technologists. This group can also practice in New York if they are licensed and in good standing in another state of the United States. Those are respiratory therapists, the respiratory therapy technicians, mental health counselors, marriage and family therapists, creative art therapists, and psychoanalysts. Okay, the following professionals are permitted to practice in New York if they have an unencumbered license and are currently in good standing but not registered. So to me, a lot of retirees are no longer registered, or you've switched your what you're doing for a living, but you were in good standing at the time, so you're no longer registered. But when you were registered, you were in good standing. You can now practice, and I don't have to go through the list. You can read the licensure list. Okay, physician's assistants. They are now permitted during the pandemic to practice within, of course, their education, training, and experience without oversight from a supervising physician. And they're allowed to practice without any civil or criminal penalty related to the lack of oversight by a supervising physician. So that's a big change. Also an executive order, if you are a medical school graduate this year in 2020, you can practice medicine in an institution under the supervision of a licensed physician. Okay. Graduates of registered professional nurse and licensing and LPN programs, they can be employed to practice nursing. This employment is limited to 180 days following graduation, and it has to be under the supervision of a registered professional nurse with the endorsement of the nursing home or hospital in which they are working. So graduates of nursing schools can practice nursing under supervision without having taken the appropriate or the licensure test. In a similar vein, graduates of a nurse practitioner education program may be employed to practice nursing in a hospital or nursing home, again for 180 days immediately following successful completion of the program. In addition, there is an executive order that nurse practitioners are permitted to practice within, of course, their education, training, and experience without a collaboration agreement with a physician. Again, this is only during the pandemic. Okay, so this is I'm getting a lot of questions regarding the Emergency and or Disaster Treatment Protection Act, which provides immunity to both healthcare facilities as well as healthcare professionals. It provides immunity from criminal liability, but also from civil liability for any harm or any damages that may be sustained as a result of an act or an omission to act in the course of arranging for or taking care of COVID patients during the COVID-19 emergency. So this is what the immunity encompasses. A healthcare facility or a professional arranged for or provided healthcare services pursuant to the emergency or otherwise in accordance with applicable law. So you are immune if this is what it is that you're doing. If the act or omission occurs in the course of arranging for or providing for healthcare services for individuals, for patients in the healthcare facility or healthcare professional's decision or activities in response to or as a result of a COVID-19 outbreak and in support of what the state's directives are, and the healthcare facility or healthcare professional is arranging for or providing healthcare services in good faith.
Lourdes,
Okay.
can I jump in? Would you speak a little bit to whether this is related to providing care for COVID-19 patients only, or patients with any medical condition, but during the public health emergency?
So this has not been, obviously, because this has just been promulgated last week or however so. But so it hasn't been tested is the answer to your question. But it's my understanding that this applies to COVID patients during the COVID pandemic. Are you with me?
I'm with you.
Okay. So what is a healthcare service? It means the diagnosis or prevention or treatment of COVID-19, the assessment or care of an individual with a confirmed or suspected case of COVID-19, or the care of another individual who presents to a healthcare facility during the period of COVID-19. Emergency declaration. What I'm not sure of, just to get back to Eve's point, is I'm not sure of how far that will go, that last bullet. And of course, this hasn't been tested yet. So let's talk about
And
what,
to that point, I have seen on some of the listservs that I get from other attorneys that the malpractice lawyers are looking at this carefully because they're not so willing to give a pass for failure to provide standard of care.
Exactly. And so that's kind of what gives me a little pause as to the other people. But even for the patients,
but it's arguable. It's definitely arguable.
Yeah. Yes. But even for the patients and that are COVID positive, or the PUIs, COVID suspected, immunity is going to apply for negligence, basically, but it will not apply for willful or intentional conduct, for gross negligence, for reckless misconduct, or for intentional infliction of harm. So I always think there's kind of the fuzzy line between negligence and gross negligence. Again, this hasn't been tested, but it is good news that this immunity is out there. And again, it's not just for the facilities, it's for the facilities as well as for the practitioners.
Right.
Now,
and
more good news
includes administrators, in addition to the institution itself.
Right. So more good news is that acts or omissions or decisions resulting from a resource or staffing shortage. Again, this is the question I'm getting all the time. Staffing shortages. What do we do about the staffing shortages? Will not be considered to be willful or intentional criminal misconduct, gross negligence, reckless misconduct, or intentional infliction of harm. So this last bullet we should put a highlight on because that is actually very good news.
Lourdes, I do see in the question box that a question came up about immunity as to whether it applies to long-term care facilities, and yes, it does. But specifically, the question is asking about what if the facility, could there be a claim made because the facility did not identify cases soon enough or isolate patients soon enough, things like that. I think that seems to me to be more negligence, not gross negligence, but that's where we're going to have to. Gross negligence is a very high bar to show, but again, it hasn't been tested.
But let's even go back to that, because one of the things that the facility, if the question is, can there be a claim because the facility didn't act quickly enough? I mean, listen, the answer is yes, always there could be a claim. The real question is, would it be a successful claim? And I think that there is enough changes in the executive orders, in the waivers, in what everybody thought of, the coronavirus and COVID-19. People's thoughts on March 8th and April 8th, and when I say people, I mean the government's thoughts and the guidance we're getting. It's changed in the last month. I couldn't even say how many times. So I think that it probably would not be a successful claim. But okay, so going on. So the immunity provisions, who are they applicable to? Healthcare professionals, whether you're acting as an agent, a volunteer, a contractor, an employee, or otherwise. Physicians, physician assistants, pharmacists, nurse practitioners, LPNs, RNs, psychologists, social workers, mental health practitioners, respiratory therapists, CNAs, okay? So a CNA is also going to have this same immunity, as well as the administrators, executives, supervisor, board members, trustees, or other persons responsible for directing, supervising, or managing a healthcare facility. Volunteers. So any healthcare facility, this is an executive order, is authorized to allow a student in a program. I've gotten this from a lot of nursing homes, a lot of questions. If you are a student in a program to be licensed as a healthcare practitioner in New York State, you can volunteer at a healthcare facility and have that count as a clinical for educational credit, as if the school had an affiliation agreement with that particular entity, even though the school may not have that clinical affiliation. So if you volunteer, the facility takes you, it's okay with the school, you can go through and count that as your educational credits as one of your clinicals. Okay, record keeping. I'm a little bit reticent to be as optimistic about these record keeping requirement executive orders as perhaps others may be. And I'm going to tell you, my concern is at the end of the day, when this is over, and please God, this will be over at some point, I am concerned that the fraud investigations will ramp up from governmental entities as well as from commercial and quasi-governmental entities. So whereas there is an executive order that healthcare providers are relieved of record-keeping requirements to the extent necessary to perform tasks as may be necessary to respond to the outbreak. This includes requirements to maintain medical records that accurately reflect evaluation and treatment, requirements to assign diagnostic codes, or to create or maintain records for other billing purposes. I get a little bit concerned as to what's coming down the line. So my recommendation would be, obviously, you have to take care of patients first. Your patients, your residents are the priority. However, to the extent that it is doable, I would maintain the same level of medical record documentation as I had in the past, again, to the extent that it's doable, because I think when this is all over, those facilities that were able to maintain, perhaps not perfect, but good records are going to be in a very different position than those that just decided, you know what, we have this executive order, let's not worry about it. And the last bullet, any person acting reasonably and in good faith for this provision will receive absolute immunity from liability for record-keeping requirements, including the New York State professional conduct proceedings. Again, when it comes to fraud, I get concerned, so I would do the best I could to actually document as much as I could. I don't know if you agree or disagree with that, Eve, but
I do. I do agree with that, because at the end of the day, as lawyers, we are going to tell you that the documentation is all you have to show that you did what you did and that you made the decisions that you did. And so whether it's the federal government on billing issues and compliance issues, or the insurers or Medicaid, or the families who decide that you didn't do enough and they're reading terrible articles in the news and they think that you're not doing things correctly when you really have been following all the guidances and trying your best, the documentation is what at the end of the day is going to help you. So
I don't know, how do we prove we're not grossly negligent unless we have some documentation?
Right, exactly. So I think that's true. So I'm going to talk a little bit about PPE and ventilators, and I know that The sense I have is that this week might be a little bit better than last week, but I still think that we're in this terrible shortage of having appropriate, personal protective equipment. This is something that the New York executive order has. There was a New York executive order that was issued. There's also CMS guidelines, which we're going to talk about a little bit. But when we were really in a crunch, in New York, an executive order was issued requiring that all entities report their inventory levels of any medical equipment that they had, of PPE, ventilators, respirators, BiPAP machines, anesthesia, and other supplies, to the Department of Health. And then the department was going to collect that material, all of those, that medical equipment, and redeploy that equipment to the facility with the most urgent need. And that after this need subsided, then either the facility where the PPE was taken will be compensated, or they'll get it back, right? And there was, as part of that executive order, there was an indication that the Department of Health would issue a guidance related to reimbursement, but I haven't seen that yet.
And can I just interrupt you for one second, Eve, because just in the last 2 days, and maybe it happened before that, but not that I was aware of, I've been getting calls from different individuals at the Attorney General's office regarding, quite frankly, numerous nursing homes, in which the Attorney General's office is asking for similar information than the information that we're supposed to be given to the Department of Health. Although it goes a little further, they're asking for staffing levels, PPE, there's like a whole list of questions that they are asking. So I just kind of wanted to put that out there because I want people to know that this is happening. Sorry.
Okay. No, that's okay. I'm just trying to make sure oh, here we go. I wasn't sure if my slide was working. Okay. I apologize for working remotely. Sometimes things don't go exactly as you plan. So in terms of optimizing PPE that's in short supply, the CDC issued a guidance for cleaning PPE, which you may have seen. And the Department of Health issued an advisory in early April, with certain recommendations as to how to handle PPE. And again, these are things that have changed and will change again. So the Department of Health first is recommending that everybody follow the CDC guidance for cleaning PPE and reusing it to the extent that you can. The Department of Health was recommending that you assign a healthcare practitioner who had COVID-19 to care for residents with COVID-19. Again, we're not sure whether someone who had it does have antibodies, but there is a basis of a belief for that conclusion. DOH is also recommending that you use non-disposable PPE that can be cleaned, that with respect to eye protection and masks and gowns, that in the beginning it was you wear one and then you change it. Now it's you wear the same protection, the same mask, the same eye protection, the same gown for multiple residents that you are seeing, and that you only change these masks or gowns when they're soiled, when they're wet, or they're damaged, or when you're interacting with a resident that may have other transmittable diseases like Candida auris or C. diff, or something that is also very highly contagious. They're also recommending that you use cloth isolation gowns that can be laundered, and that you can use alternative cloth gowns like a laboratory coat, or cloth patient gowns, or disposable aprons, or a combination of that. So, I've seen in the news that, facilities are being, vilified for using cloth patient gowns, but that's exactly what the Department of Health recommended, that if you don't have a cloth isolation gown, that you use one of these alternative types of cloth, protective gear that can be laundered. Prioritize face masks for healthcare practitioners and reuse the face masks as per the CDC guidance for cleaning, as well as for folding it properly and storing it in a breathable container. So there's a whole discussion in the Department of Health advisory and in the CDC guidance of how to properly fold the face mask in, how to put it on correctly, how to take it off correctly, and how it should be fitted properly, all of that. So again, that's all in the CDC guidance and the Department of Health advisory. In addition, the Department of Health issued an advisory on N95 respirators to use them on an extended basis and wear them for multiple residents, and you only should change them when they're soiled, wet, damaged, or difficult to breathe through. Assign the N95 to a single healthcare practitioner and store in a breathable container for reuse. And they also recommended using expired N95 respirators and respirators approved in other countries. But here there's a warning that you should look at the CDC and FDA guidance. And when we wrote the slide, these slides, this was the links that to the CDC and FDA guidances on acquiring N95 respirators from other countries. In particular, there's a warning that in China, there are certain manufacturers who are known to provide quality merchandise, and then there's a list of those who are providing counterfeit documents. So they are recommending that you check the FDA guidance as well as the CDC guidance so that you are ordering equipment from a reputable provider. So let's shift a few moments where we're almost at the end of our hour. I also want to mention with respect to PPE, I know that there was a lawsuit recently filed of having insufficient PPE, so I'm sure there's going to be more on that with respect to the supply and the lack of supply for many facilities. And I think that was started by nurses, by the Nursing Association. So I want to spend a moment talking about the expansion of telehealth. And this is something that I think, we're going to see some of the changes here implemented, I think, on a more going forward basis, because it's been a tremendous help, I think, and a boon to providing services. First, there are the 1135 waiver that Medicare providers may now provide telehealth services to beneficiaries residing in both rural and urban settings. It used to be more, only rural settings, but now that's been opened up to be provided in any setting. The Office of Civil Rights has been directed to exercise enforcement discretion and waive penalties for not complying with the HIPAA requirements with respect to privacy and security and using certain telehealth technologies. And just today, I didn't have a chance to revise the slides prior to our presentation today, but just today in the Federal Register, HSS is indicating that the Office of Civil Rights will not impose penalties if you're acting in good faith, and if you don't have a business associate agreement, that's okay. In the Federal Register today, they indicated that if you're using everyday communication technologies, they have to be non-public facing technologies. So things like FaceTime, Skype, Zoom, Google Hangouts, Facebook Messenger video chat, those are all okay. What's not okay are Facebook Live, Twitch, TikTok. These are public facing technologies, and so those are not acceptable. With respect to telemedicine in a facility, in a nursing home, a staff member we'll need to facilitate the telemedicine experience for our residents with the clinicians and manage the technology for our residents. I mean, I don't know how many residents are too facile with computers and have their own, laptop or iPad or phone. I mean, my father-in-law was great at it, but I'm sure that not a lot of 88-year-olds are too good on using some of these technologies. So this list on this slide talks about who can provide telehealth services and bill for them. I should mention that under Medicare, billing under telehealth is the same as if it's a face-to-face visit. So the list of providers is quite extensive. It includes physicians, nurse practitioners, physician assistants, nurse midwives, clinical nurse specialists, clinical psychologists, clinical social workers, registered dietitians, and nutrition professionals, as well as certified registered nurse anesthetists. So anesthetists. So that's a very long list of providers who we may be able to utilize in terms of the services that we are providing in our facility to allow all of those services to continue, but to do so in a telehealth environment. Medicare did put out a toolkit. This is a link to the toolkit and just a table of contents, so you can see how detailed it is. It's really very helpful. It not only describes the 1135 waivers that apply and how they apply, but it really sort of breaks it up and shows you what type of service and the HCPCS and the CPT codes that you may need. So there are telehealth, by the way, can include not just video, active video conferencing, but it could also be telephone if that's, all you have. So it can also be a telephone visit. I just wanted to mention that as well. It doesn't have to always be video. But there are, certain types of service. There's the Medicare telehealth visit, which is using a telecommunication system between the provider and the patient. And in the past, you could only do this for established patients, but in the public health emergency, this is now available for new patients as well. So that's part of what the 1135 waiver allows for. There's the virtual check-in, which is more of a brief 5-10 minute check-in, and that is only for established patients. And then there are e-visits where there's just an electronic communication. That has to be initiated by the patient. That's not something that is initiated by the practitioner. So the other big news is that Medicaid also expanded telehealth services, and Medicaid will reimburse a telephone assessment, monitoring, evaluation, and management services where you would ordinarily have a face-to-face visit. If the face-to-face visit is not recommended and it's appropriate for the beneficiary to be evaluated and managed by telephone, that is permissible. That was big news. So who can provide telehealth services and bill under Medicaid? It's a very extensive list. Under the current, because of this public health emergency, providers include physicians, podiatrists. I'm not going to read the whole list, but you can see that physical therapists, occupational therapists, speech language pathologists, audiologists, nurse practitioners, they're all on the list of who can provide telehealth services. For telephone reimbursement, this is a copy of the slide, right from the website as to who is permitted to provide telehealth services and how they can provide that, as well as the CPT codes. And let's talk a minute about consent, because in the past, written consent was required for telehealth services, but during this current public health emergency, written consent is not required. A practitioner does have to explain to the patient they can explain what a telehealth visit is, And then once they do that explanation, if the person consents, if the patient consents to the telehealth, then that is acceptable so it can be a verbal consent. And then that should be documented in the medical record. A recording of the telemedicine or telephone service cannot occur without the beneficiary's consent. So that's something to just keep in mind. So I want to take a moment to look at some of the questions that were posted.
Yeah, Eve, one of the questions posted, which was posted beforehand when you were talking about advising residents and their family members when somebody tests positive for COVID. One of the questions was, what if the resident has no family or next of kin or surrogate? What do you do about a notification?
Then I don't think there's any notification to give because there's no one to give notice to. I think what we're talking about with notification is really giving notice to the designated representatives and healthcare decision makers and family members who are identified, on if you have that information in your charts. And with all of the movement that is happening from hospital to nursing home now with new patients, that's going to take a little digging. So you may not have that documentation right away from the hospitals because they're not documenting certainly as well as they normally would. You may need to try to do a little digging to find out if there is family, which quite frankly we should be doing anyway, because what if we have a situation where we need a healthcare decision to be made and you have a resident who doesn't have capacity? So.
Right. And I think that is the only question that we had not answered during the presentation. If anybody has any questions, please feel free to post them now.
And also, I want to mention, we do have at the end of the slide here, there's more information on telehealth resources that we had at the very end. And just to remind everyone that all those who registered will receive an email with a copy of the slides as well as a link to the webinar so that you can share this with other members of your team and in your facility. And we thank you for joining us.
Yes, thanks everybody.
And stay well.
Yes. All right. We're going to sign off now, seeing no other questions. Thank you.
Okay, very good. Thanks everyone. Bye-bye.